Thank you, Dr. Santan Gopal. I think I really empathize with the postgraduates, the present-day postgraduates. I never forget my days of post-graduation in 1980s. And that is why my job is to simplify things. If you have read the book on strabismus, my job is not to get the whole book in 30 minutes. You can go back and see it anytime. The idea is that we should know the basics and remember that. Because education is not the learning of facts, as we have been talking about since morning till evening, but it's the training of the mind to start thinking. And fortunately in strabismus, we do not have to remember too many facts, but just to understand the concepts and practice it. What changes have occurred? One is important, that our job as an ophthalmologist is not to give back 6/6 vision or 20/20 vision, but to get the binocular vision which God gave us, retained, maintained and promoted. So our job is to have stereopsis, which is something which most of the time we forget. Squint, sight, we know, but we mostly don't know about stereopsis. That is something which the present generation is going to be asking you. The children are exposed to 3D movies and 3D TVs, and they will come back and say that why I can't see in spite of 6/6 vision in each eye, why I can't see the movie which my friend can. So can you see 3D movie? After a few years, probably you will be seeing here a 3D presentation, I'm sure. So the near stereopsis you may have seen being done by the Rendot or the TNO test, in which red and green glasses are used. But remember, as for the exam purpose, if you want to remember, the red is on the reverse side. The red is on the left side, whereas for diplopia goggles, the convention is red on the right side. Many examiners take pride in these sort of questions. Not me, but yes, these are there. Then we have the distance stereopsis tests, which are like Frisbee-Davis distance, for distance at 6 meters, or the distance Rendot done at 3 meters distance, which is basically a type of random dot near stereopsis, but made for a 3 meter testing. Again, you'll require Polaroid dissociation. But a simple bedside test which you all can do is a Lang's 2 pencil test, examiner holding one pencil and the child holding another. And if he or she has binocular vision, which is giving stereopsis, then only she can do, this alignment can be done. Otherwise, she will be missing it in this manner. Squint is little different. It's not like cataract, you just see it and start operating. Does this eye appear to have a squint? How many of you feel there is a squint? Just raise your hands. Okay, so those who think there is a squint are going to be wrong. Because sometimes we are deceived like this. An apparent squint may be considered. The first thing is observation, which is good. But second thing is confirmation. Then inference, planning and execution. This is what I say OCIPE is my recipe for strabismus. Now this case which you were seeing earlier, now what do you think? There is a squint, it appears because of a large telecanthus and the epicanthic folds which are there. So this child appears to have a esotropia. And when she looks to the side, this definitely appears more so because this eye is hidden almost by the epicanthic fold. And also appears to have an inferior oblique overaction if you cursorily see that. This girl appears to have a esotropia again because of large palpebral apertures, what we may call as euroblephron, but I think the Hindi literary people might call it mriganayani, somebody who has large eyes, but this appears to have an esotropia. Here it appears to be an exotropia. But all these, mind you, are pseudo or apparent squints. And what you simply need to do is a cover test, which is simple. Even if a child doesn't cooperate for anything else, you can use your thumb. So a thumb rule is just cover the eye which appears to be fixing and look for the eye which was appearing to be deviating. If there is a true squint, it will deviate, and if it is an apparent squint, it will not move. The other thing which you need to remember is the glasses. You need to have a proper cycloplegic, age-appropriate cycloplegia. For children less than 5 or 6 years in our population, we need to have atropine cycloplegia. And you need to give them proper glasses before you assess whether their squint needs to be operated or not. It may be just a plain, simple, accommodative esotropia which needs just glasses and sometimes bifocals. Because when you may see that for near, they still appear to have straight eyes for distance, but for near with an accommodative target. Mind you again, no torches, but accommodative targets are what we'll be using and we'll see that. So distance and near both needs to be measured. The same deviation you can be seeing it to be differing when we make him fixate for distance or make him fixate for near. Similarly, if there is a convergence insufficiency, for near you might see the exo is increasing, whereas in primary position here it is not much for distance. So these are something which we'll do. So we need to have a proper examination when you're doing a simple prism bar cover test. But for distance and for near, both need to be done, because we might see the ESO and exotropias varying in this fashion. It may be a basic type when both near distance deviation same. It may be convergence excess type ESO or a divergence insufficiency. Similarly, a exo. The other thing is lateral incomitance, but then don't forget the binocular status to be examined. It may be a problem of correspondence, that's a normal lateral correspondence or an abnormal lateral correspondence, or it may be the problem of amblyopia, when the vision is poor in one eye, and you need to treat it before you jump to the dosing and management of the strabismus cases. And what you do is simple occlusion or opticlude roles which are there, and the age-dependent alternation. You need to see that the better eye is occluded more times, up to 2 years, 2:1, and as the age advances, 3, 4, 5, 6:1, but it remains the same. Never say beyond 7 years, 8 years age, 7:1, 8:1. Sometimes I get this funny answers. It is going to be just 6:1 because the week has just 7 days. Monitoring fortnightly in infancy, monitoring monthly later, and continue till vision improves or fails in 3 months time. We will know that in 2 consecutive visits, monthly visits, we will know whether the vision is improving or not, and later on we have to then switch on to maintenance occlusion. So this is about the amblyopia therapy. Remember, it's the age which is the most important factor. Early detection and presenting vision. The poorer the vision, poorer the prognosis. Compliance is another important factor. So you need to have these ensured if you have ensuring of the binocularity and stereopsis. Prism bar cover test. Never the Hirschberg's deviation, because Hirschberg's will tell you very grossly, and it will be many times wrong because of the angle kappa that will be there. So use prisms and measure the deviations with the prism bar cover test. Remember, when you're using prisms, never use prism over a prism, because then it will be a fallacy. And you need to split the prisms over the 2 eyes when you're using them. And otherwise you will get an error. So never stack prisms, split them over the 2 eyes. Now when you have a child having large refractive glasses being worn, remember this will induce prismatic deviation. A prism base out prism effect is there whenever a phakic glass is being used or a high hypermetrope glass is used by a child. You see this is a base out prismatic effect in front of an esotropia, and what you measure will be less than the true deviation. Whereas in an exotropia, the base in effect will come in for an exotropic eye, and you will have a measurement less than the true deviation. So remember, a plus lens will always have a lesser measurement than the true deviation, and a minus lens, M for more, M minus lens will always give you a more measurement, and you need to correct it with the tables or a formula which is there in the books. Then when you examine the eyes in the 9 gazes, don't get foxed. First of all, have your attention on the center primary gaze. Look what is happening here. The eyes appear to be straight. When you look up, what is happening? There is an exo divergent squint, and on looking down there is an ESO deviation. So you might feel confused. Now is it an ESO deviation, is it an exo deviation, or is it an ortho? In fact, it is changing different gazes. And then when you look to the side, what you see here, there is a hypertropia of the adducting eye, of the right eye, and here of the left eye. So bilateral hypertropia in adduction is there, which will mean it's a bilateral inferior oblique overaction. So this is a case in which primary position the eyes are straight, but there is a bilateral inferior oblique overaction causing a true V pattern, right? So such a 9 gaze pattern, if shown to you, will be indicating that there is a, so if you have assessed it properly, done the inferior oblique surgeries, like what we did in this case, you have a ESO corrected, exo corrected, and the hypertropia also corrected. So when we have these deviations, remember you have to examine the eyes with the panning of the thing, and you'll see that the exo is increasing in the up gaze and decreasing in the down gaze. And when you measure the prism bars, you'll see that the difference is more than 15 prism diopters for a significant V pattern. For an A pattern, we'll take a difference of more than 10 prism diopters, but what is happening here is the exo is becoming, the ESO in this case is becoming less in the down gaze and more ESO in the up gaze. So you see an A pattern. So these are simple alphabetic patterns that we are using for remembering the type of deviation that we are going to see. And we'll examine the eyes in the primary position, in 25 degrees up gaze and 25 or 35 degrees down gaze. Why have we more for down gaze? Because down gaze is more important than the up gaze, and we need to examine that up to 35 degrees, and you can use the mirror which is marking or a simple protractor. Whenever you have a V pattern, look for inferior obliques along with. Overaction of the inferior obliques is associated with V pattern. Overaction of superior obliques is associated with an A pattern. Like in this case, again, you see here, can you all see? This is an exo becoming less in down gaze, becoming more in up gaze. And then when we look to the sides, there is an hypertropia of the adducting eye. Simple, it's basic observation and confirmation. And if you see this, it's a V pattern exo with a bilateral inferior oblique overaction. So this is what you need to do, and you will examine it by confirmation with the cover test. But all cases of V pattern exotropia do not necessarily have an inferior oblique overaction. So don't jump to that. If you have exotropia which is becoming less and more in up gaze here, but you find that hypertropia is not occurring in adduction, this is a type of V exotropia without inferior oblique overaction. So you need to see the inferior limbus in between the two eyes to see if there is a real hypertropia or not. And if you find there is a difference in the two eyes, sometimes there will be more inferior oblique overaction in one eye than the other one, and you can see the amount of inferior oblique overaction. You can grade them as mild, moderate or severe. You can also use and these pictures are there in the books, how much angle it makes the hypertropic eye. If it is 90 degrees, it is 4 plus. If it is same way, you can do it. Now for the A exotropia, you will see the eye dipping down. It's an hypotropic eye in adduction, and that is what you will examine, right? A esotropia with superior oblique overaction here. You'll see that exo is becoming less, less in the down gaze and more in the up gaze, and there is a superior oblique overaction. Hypotropia of the adducting eye. In this case, it is not. So you need to examine the 9 gazes when you get into these pictures as the Oskis or whatever. And if you will never have a problem if you go step by step. First the primary position, then look up, look down. What is it? It is looking like an A pattern. Then look to the sides. What is happening to the eye in adduction? Is it the superior limbus are at the same level? So there is no superior oblique overaction in this case. So where there is an A or V pattern associated, and look for the obliques if they are significant or not. And then we will plan our surgery. How much do we do? It will be based on first, how much is the horizontal deviation in the primary position, and if there is any associated A or V pattern, we will see if it is having a significant oblique overaction. If that is so, then we will have to weaken the obliques. Otherwise, we will do a differential R&R or shifting of the R&R up and down. The tables are available for deciding how much deviation and how much millimeters of muscles you need to recess or resect. And you can use all these are there. But remember, in children, you will have to use lesser amounts because the eyeball is smaller in a child compared to the adult. And the safer limits are going to be lesser in an infant. MR is 5.5 compared to 6 millimeters for an adult, and the LR is 6.5 for a recession. For the resection, it depends upon the tendon length. And you don't want to exceed more than 10 or 15% of the length of the muscle if you want to have a strengthening effect. This is how a upshift or a downshift can be done. So we have all the 9 gazes covered. The primary position, levo, dextro elevation, dextro depression, and all these 9 gazes have been seen. And we can see what is happening in the different gazes. There is an exotropia becoming less here, becoming more here, and hypertropia, right? We also need to see the torsion, because another dimension which we are having a capability of the eyes moving is there can be an extorsion. What do we mean by extorsion here? The fovea is dipping down, much below the horizontal line passing through the lower pole of the disc. The normal location is supposed to be above this, and a line, horizontal line, which is 1/3 of the disc upper and lower border, will define the upper limit. Here you see that this is the upper limit and this is an intorsion. So you need to examine the fundus, and you can see on an indirect ophthalmoscopy easily whether there is an intorsion of the globe or an extorsion of the globe along with. When you see a child, he may be having straight eyes, but at 3 months old, the same child starts developing an esotropia. And if you do a proper cycloplegic refraction, give him glasses, there is a esotropia still there because of Bruckner's reflex. Now what is the Bruckner's reflex? If you shine the light with the ophthalmoscope, larger aperture at 1 meter distance, you will see equal illumination of the red glow of both the eyes. If there is a brighter reflex, it means there is a squint. And if you find this is happening, this needs surgery, maybe at 6 months or at least before 1 year of age, and then only we can have them binocular vision. But intermittent exotropias, you can delay till about 4 or 5 years of age. So the golden rule for timing is up to 4 to 6 weeks we remember for congenital cataracts. For infantile exotropia, 4 to 6 months we should be able to decide and operate by 1 year. Intermittent exotropias decide by 4 to 6 years, and refractive errors or nystagmus 4 to 6 years again. Now we'll have a brief the surgery video of the horizontal recessions and resections. How an LR recession and MR resection is done by the fornix approach. Remember, we sit on the side of the patient so that we can approach the muscle to be operated looking directly. The fornix incision, we are passing a anchoring suture with the 1-0 cotton suture, and then 7 to 8 millimeters from the limbus here we will make a nick. The conjunctival incision is made here, the fornix incision. It will be a small incision, and after this we see the Tenon's capsule, and then the second nick is made in the Tenon's capsule, and we stretch it just to reach the subtenon space. We remember we need to operate in the subtenon space for strabismus surgery. And then we are going to hook the lateral rectus here. See, the hook is being passed first in the reverse direction so that we hug the sclera and we get the full width of the muscle in our hook. The first hook is the Jamieson's hook. And the second one which we passed, which has a little bend to, that's the Green's hook. And then now the third hook, the Lenz hook, is being used to bring the muscle in our field of surgery. Now, what you see here is an intramuscular septum, which a small nick is made, but we need to examine whether we have the full width of the muscle or not. So another Lenz hook is used here, a 2-hook maneuver of Kenneth Wright, as he is described. You can see the pole. This pole of the or the other end of the muscle insertion, which ensures that the full width of the muscle is there in your hook, and the other hook is applied. Then these are the check ligaments which you are seeing here. A direct vision dissection is done up to 8 to 10 mm. The check ligaments are being excised, and on either side the intermuscular septum has been dissected. And now we are using a 6-0 vicryl suture. Full thickness bites are taken in the muscle, first in the central part, and a knot is placed here, and then we will pass 2 interlocking bites at the upper and the lower pole of the muscle. And this is 0.5 to 1 millimeter from the insertion of the sclera. So this is how the muscle is being taken into our bite with a 6-0 vicryl suture, and then we will disinsert the muscle, and if there is a bleeding at this point we will use a light cautery. Remember, if your sheath is intact, you should not have bleeding in the muscle surgery, but at this point it may be there, and then when you are holding, you displace it by your holding by 1 to 1.5 millimeter. Never use this point for marking. The point of holding should never be used for marking. You use the poles if you are holding from the center, and if you are holding from the poles, then mark from the center part. So these marks will be placed perpendicular to the insertion, 7.5 millimeter. So that was the Castroviejo calipers, and the perpendicular mark is made. Now the partial thickness bites are taken in the sclera with your spatulated needles, both coming facing each other, and finally we are going to tie the muscle at this point and ensure. The only difference in resection is that we will have to take 4 muscle bites so that the muscle which is going to be tighter, after a resection the muscle is going to be tight. After recession the muscle becomes lax. I generally say students who are taught TAUGHT, they become more stronger. Similarly, the muscle which is taught TAUT becomes stronger, and the muscle which is lax, like a lax student, will become weak. So this, and then you can close the conjunctiva. Now the general surgical tray would have these instruments. You may have seen all of them. And what are the complications which are possible, which may be kept in mind? Operation on the wrong eye. It's very much possible in the strabismus if it is not taken care of. Operation on the wrong muscle. You may have planned for the MR, then you have operated on the... So you have to have a written plan before you operate. Wrong operation performed. Instead of recession, you did a resection. Shifting in the reverse direction. All these have happened. Hemorrhages, scleral perforation. All these can happen, but they have to be avoided by proper learning. Like the mosquito mother trains the child, pull out Betty, pull out, you have hit an artery and you will get bloated up. So same thing happened to us. We have to pull out of the situations and not do that. Avoid splitting the muscles. Proper orientation of the globe has to be there. Clean dissection of intramuscular septum, hooking under direct visualization. The first hook is critical, avoid hurry, and a 2-hook maneuver as I showed you in the fornix incision will take care of this. And avoiding the wrong rectus. Remember, the superior and the inferior recti have slanted insertions. They are more far temporally compared to the medial and the lateral recti. And then the measurements, when we want to make larger ones, instead of the Castroviejo calipers, we'll use curved rulers, or we may use a bent iris depositor for marking. Then these things like muscle sheath rupture, partial thickness bites in the muscle, loose sutures, central sag, slipped muscles or lost muscles, or orbital fat prolapse, by a proper surgical technique you will not have them. And if you have not taken full thickness bites in the muscle, then you end up having a slipped muscle. PONV or post-operative nausea vomiting is very common with strabismus. Tenon's prolapse may occur sometimes if you are not careful. Infections can occur, suture granulomas, conjunctival cysts and Dellins, like exposure causing a dehydration of the sclera which is exposed if there was a conjunctival recession done. And this is an infection of a fungus from the skin which the child had it. So these can be avoided. Anterior segment ischemia is something which is avoidable problem. Never do 3 contiguous recti muscles to be operated. You have to avoid 2 vertical and a horizontal rectus. 2 horizontal rectus we routinely do, but we don't add a vertical along with it. Otherwise, anterior segment ischemia can occur, and you can, if you have to do the 3rd muscle, you will have to spare the vessels. Adjustable surgery, whenever you're not sure of or when there are special problems, then you can adjust the recession or a resection or even an adjustable Farden. This different technique which is there in that would be, instead of the marks are being placed here, but we will have a hang back suture in this case, and we will also pass the needle radially coming towards that, so that it will be easy for us to adjust rather than the circumferential passage of the needles. And then we'll take a second bite in the insertion, and this is a silk suture in between which will help us in releasing the knot, and a 1.5 knot will be passed, so that we have a adjustment possible after 5 or 6 hours of our surgery, when the effect of the anesthesia, peribulbar block or general anesthesia has passed off. And this is how the muscle is being hanged back, and you can adjust the amount of recession at the time of the adjustment, that is 6 hours after the surgery. So these are the important steps in the adjustable surgery that you need to remember. So I would like to keep my talk here and keep some time for some questions. That you have anything which you have not understood. I believe that things cannot be taught in 30 minutes as a didactic fashion and sort of toxify your minds. What we need to do is excite your attention, you understand little bit, you have an enthusiasm to learn more from the books. But if you have any queries, I think we have 6 minutes, we can talk about that.